General principles: medical and surgical patients with hyperglycemia are at increased risk for poor outcomes. 102 The fact that hyperglycemia is a marker for poor outcomes appears to be relatively clear. However, whether aggressive management truly improves outcomes is uncertain. Trial results have been mixed. Treatment: elective surgery in patients with uncontrolled diabetes mellitus should preferably be scheduled after acceptable glycemic control has been achieved. If possible, the operation should be scheduled for early morning to minimize prolonged fasting. Frequent monitoring of blood glucose levels is required in all situations. Type 1 diabetes: some form of basal insulin is required to prevent ketosis. On the evening prior to surgery, the regularly scheduled basal insulin should be continued. If taken in the morning, it is still recommended to give the regularly scheduled basal insulin without dose adjustment. 103 However, patients who are tightly controlled may be at increased risk for hypoglycemia and will need to be monitored closely. A decrease in the last preoperative basal insulin dose may be considered in this circumstance. Glucose infusions, e.g., D5 containing fluids, can be administered to avoid hypoglycemia while the patient is NPO and until tolerance of oral intake postoperatively is established. For complex procedures and procedures requiring a prolonged NPO status, a continuous insulin infusion will likely be necessary. Caution should be exercised with the use of subcutaneous insulin in the intraoperative and critical care settings, as alterations in tissue perfusion may result in variable absorption. Type 2 diabetes: treatment of type 2 diabetics varies according to their preoperative requirements and the complexity of the planned procedure. 104 Diet controlled type 2 diabetes can generally be managed without insulin therapy. Glucose values should be checked regularly 4 times daily at minimum. Elevated levels greater than 180 mg/dl can be treated with intermittent doses of short-acting insulin. Type 2 diabetes managed with oral therapies: short-acting sulfonylureas and other oral agents should be withheld on the operative day. Metformin should be withheld 1 day before planned surgical procedures. Metformin is generally held for 48 hours postoperatively provided there is no acute renal injury. Other oral agents can be resumed when patients are tolerating their pre-procedure diet. Glucose values should be checked regularly and elevated levels greater than 180 mg/dl can be treated with intermittent doses of short-acting insulin. Type 2 diabetes managed with insulin: long-acting insulin, e.g., glargine insulin, can be given at 50% of the usual dose the day of surgery. Intermediate-acting insulin, e.g., neutral-protamine hagedorn, can be given at 1/2 to 2/3 of the usual morning dose. Dextrose containing IV fluids may be required to avoid hypoglycemia. The usual insulin treatment can be reintroduced once oral intake is established postoperatively. Target glucose levels: there are no generally agreed upon target glucose levels applicable to the entire post-surgical population. Pending further research, the goal of maintaining glucose levels less than 180 mg/dl in the postoperative setting seems reasonable. It should be noted that this may still require intensive treatments such as insulin infusion. In patients treated with sliding scale insulin, it is essential to monitor the response to therapy. Patients who are hyperglycemic consistently are unlikely to have adequate glucose control with intermittent treatment alone, and a basal/bolus regimen should be introduced if hyperglycemia is persistent.